All right, I see our attendees list ticking up, so I'm just going to give a few introductory remarks, and hopefully everyone that joins in won't be left out of the loop. So welcome. Today is an exciting and important topic, inclusive and equitable public health engagement. This webinar is part of a series of webinars that the Colorado Resiliency Office is doing. The Colorado Resiliency Office is out of DOLA, the Department of Local Affairs, the Division of Local Governments, and I'm putting the link in the chat now for the website where not only this PowerPoint and recorded webinar will be posted, but where all of our previous webinars are also posted. So if we could advance the slide. Thank you all for joining. I just want to go over a few obvious logistics. Most of you have been muted by the webinar itself, but you are welcome to join via chat to communicate any questions at any time during the presentation. We will have a solid amount of time at the end to get to any of your questions, so feel free to use that chat. Please also ensure that your microphone is muted in case it somehow isn't. And again, this webinar will be recorded and available online. So let's go to the next slide. I'm going to provide a very brief introduction just to set the stage for the webinar. But we have a whole slew of panelists from the state to regional to county to municipal organizations that are representing the work that they're doing in their communities around inclusive and equitable engagement in public health, but specifically during this time of COVID. So again, at the end, we will have time for Q&A. Let's go ahead. Next slide. And here are pictures of each panelist. We won't be doing video because it will help with bandwidth and the Wi-Fi, but these pictures show some of these faces that will be representing their work, and I am excited and thankful for all of them to have been able to join. You know, this is a little bit of extra duties as assigned, you know, them taking on representing their work on top of all their other COVID-related response, so thank you all for joining. And I will jump into just setting the stage with the next slide. So before I do hand it over to the panelists, I just wanted to share some data from the national, and then the next slide will be the state perspective on why this topic is really important. And I find it helpful to frame the conversation around impacts in the left column and response in the right column, or in other words, you can think of this as the depth of the problem and the depth of the hopeful solutions. So some of the data I pulled out represents equity in terms of race, but obviously equity is a much bigger conversation than that, and I'm thankful that our panelists will be hitting on some of those other demographics. Race is definitely an important part of that conversation though, and as you can see here in the left column, you might have already seen these graphs. They're from the New York Times and Times, and they represent both the health impact based on race as well as the economic, or in this case, the unemployment based on race. And what you can take away here is that, you know, COVID really is impacting Black, Indigenous, and people of color people disproportionately more negatively than white and non-Hispanic populations. And here on the right, I've tried to highlight some of the responses that have been going out. So how are we supporting these communities that are bearing the brunt of the impact? And looking at just economic impact, I've highlighted some media outlets that have been researched and criticized some of the early efforts to support minority-owned businesses, specifically around the PPP, or the Paycheck Protection Program. So I've underlined in yellow this line at the bottom of the slide here that says, you know, if someone had understood the barriers that Black businesses face, they might have been able to avoid some of the problems that happened with PPP. And if we advance the slide once more, what are those barriers? Well, this graph shows that BIPOC communities face some barriers in accessing capital. So this graph is actually from a normal during pre-COVID times, but clearly the cascading effects of these influences still impact BIPOC communities during COVID funding as well. So it's really important that we ask these questions, not just at the national level, but also at the state level. I will say it's notable and hopeful that since recognizing these issues of disparity, on May 28th, the federal government did set aside $10 billion for CDFIs, or Community Development Financial Institutions, which primarily work as lenders for businesses in underserved and rural communities. So hopefully we will be reversing this early trend. So on the next slide, I've pulled out some state data that does echo this national data. And so the calculation I've done here is the percent of the population minus the percent of deaths. And it shows that there is an 8.77% difference here in Colorado between the death rate of white, non-Hispanic groups, and Black individuals, as well as disparities across other minority races. And that also carries over to the not just deaths, but the number of cases. So the takeaway here is that race is a social determinant of health in a literal life and death way. And in terms of the response and recovery impacts, there's still little quantitative data to assess how we are responding to this disparity. But anecdotally, you can see that the Energize Colorado Gap Fund is prioritizing funding for minority groups. And this fund will provide more than $25 million in small business loans and grants. So this data was provided to me in support by our DOLA State Demographics Office and Elizabeth Garner, who is in the chat now. My hope with these slides is to just illustrate the importance of having an equity lens as we look at COVID impacts and responses, but also so that we take active steps in changing this data within our own communities. I think we all just need to be asking ourselves who is the most impacted, and also how to work within our community to better serve these hardest hit and vulnerable populations. And with that, I'm excited to dive into the more specifics of some of the communities that we'll be highlighting. And first, we'll start from a state perspective with Cristobal Rojo with the CDPHE Office of Health Equity. So Cristobal, over to you. And you may see, oh, there you go, perfect, thanks.
Everyone, can you hear me okay? So hi everyone, and thank you for having me today. And most importantly, for being here in this space where we can connect, learn, and share with one another. I'm Cristobal Rojo, as Margaret had indicated earlier. My role specifically is focused around language justice and community partnerships.
Cristobal, I'm sorry, your audio is a little bit muffled. Is there a microphone you can pull closer to you?
I'm on my laptop, but the all on screen. Sorry about that.
Oh, that's a bit better.
Okay, perfect. Okay, so I'd like to start off by telling you a little bit about our office's work and our role in the active COVID-19 response in partnership with the Colorado State Joint Information Center through their communication structure. And I'll also share some lessons learned, and also be talking about the work of the COVID-19 health response team. And as I continue my presentation, I'll be referring to the health equity response team as ERT team, or team, just for reference. And also just showing how critical they have been in informing the current gaps in public health emergency response. The inequities that COVID-19 has shed light on have always been with us, but now they're at the table. And so during this response, OET team members have been engaged as active thought partners with Joint Information Center. During this collaboration, we quickly realized that there were processes and decisions being made without an equity lens. And that became apparent as COVID-19 impacted communities of color. The office, along with the ERT, helped incorporate an equity lens into guidance documents before they were implemented or shared publicly, which otherwise wouldn't have been prepared with an equity lens in mind. Inequities are multi-sectored, multi-layered issues which significantly have an impact at the social and economic and health level. Next slide. I wanted to start off by sharing OET's mission with you all, which is to build partnerships to mobilize community power and transform systems to advance health equity and environmental justice. And the reason I share this with you all is because COVID-19 has emphasized and shown light on how important building partnerships to mobilize community power in decision making that directly impacts communities is. It goes beyond partnerships and involves us asking ourselves who these partnerships are with. How can relationships be mutually beneficial? What can you offer? And also acknowledge that government has historically marginalized communities. And so also part of partnerships is to consider leveraging both multi-sector and grassroots organizations. And so the work of the office focuses around coaching, connecting, and changing in order to advance equity, diversity, and inclusion. Next slide. And so why is equity so important today as we're in this global pandemic? Well, it's always been important, but now more than ever. The way that OHE defines equity is when everyone, regardless of who they are or where they come from, has the opportunity to thrive. This requires eliminating barriers like poverty and repairing injustices in systems such as education, health, criminal justice, and transportation. Another way I like to think of this is when your identity has no impact on your outcomes. In other words, it doesn't matter who you are, race, religion, sexual orientation, ability level, language you speak, etc. All those social inequities, all those social identities have no impact on your ability to achieve in life. Now, the reason for why OHE exists is because we have so far to go in order to get there. And data tells us that social identity, whatever it happens to be, has everything to do with your life outcomes as it relates to healthy systems in Colorado and even more broadly in our country. As a result of this, we have seen the loss of lives from racial inequities due to COVID-19. Next slide. At the start of the pandemic, there were practices where data was being captured without consideration of a racial lens. As a response to this, Governor Polis established the COVID-19 Health Equity Response Team, headed by the Office of Health Equity. The ERT was convened because COVID-19 shed light on data inequities. And so the goal of the ERT is for Colorado to focus specifically on tackling these inequities, prevent gaps widening, and ultimately saving lives. The ERT is made up of organizations and organizing leaders. And so their initial recommendations in response to COVID-19 focused on, and you'll see them listed here. But as I go through them, I invite you all to ask yourself why. Why were these recommendations made? What were we missing in the wake of responding to this pandemic? So the first one starts with ensure racial and ethnicity COVID-19 data are accessible, transparent, and used in decision making. So early on during the COVID release of data, the initial data that was being presented was misrepresenting communities that were being impacted by COVID-19, specifically by racial identity. Determine proactive measures to prevent the spread of COVID-19 in specific communities was a second recommendation made by the ERT. And there are communities that are heavily being impacted. And so the question is why? Where are the resources? What communication is being received and how or not received? And so this is a call to the fact that partnerships with community grassroots organizations and leaders are critical. And during the time of a pandemic outbreak, it's not the perfect time to start building these relationships. And it's not to say that it's not possible, but they do take time and they require a mutualistic benefit. We need to have these partnerships established so community voice can inform what is best needed for communities from the beginning, and also so that barriers are identified from the beginning. So that all communities have a voice in the process for how resources and information are being shared with the community most impacted. This was a big lesson learned, and so the office helped leverage existing partnerships to inform processes, but the reality is that the office doesn't have all the connections, and we don't know everyone's work. You are all the experts, which is why we encourage building partnerships with communities and with work serves. Work with state team coordinating resources and logistics to help curb health disparities related to COVID-19. That was another recommendation that came out of the ERT. And this was specifically focused on having a ERT representative serve as a liaison in the Joint Information Center. So again, having community voice at the decision-making table. And then increase access to testing and care services. This had been burdening many community members. So as a result of this, OHE and the ERT worked collaboratively to create the equitable testing guides for testing sites and contact tracing. And with that, we embedded an equity lens to that process to ensure that community was having access to testing and also being approached in a culturally and appropriate manner through contact tracing. Share time-sensitive information about how Colorado communities are experiencing particular challenges related to COVID-19. This brought to the attention the strategies being implemented to ensure communication is culturally and linguistically appropriate. CDPHE, in collaboration with the Joint Information Center, hired 2 on-staff translators who have been actively engaged in the COVID response communication. We quickly learned that there were indigenous languages that were being left out from receiving and accessing culturally and linguistically appropriate information, including accessibility issues that were missed initially. So communication efforts were suggested by the ERT in the COVID-19 response, and the team presented alternative communication methods to reach communities, such as WhatsApp, video through community artists, Facebook platform, etc. So again, getting at what are the trusted networks that community leans on for information gathering. This was an equity and justice and language justice issue identified as certain communities needed access to information about COVID-19 in the language they speak, read, and in a manner that they accept through trusted community partners in order to protect themselves and others from disease. So it's not only about having information out there, but how that information is being communicated and who it's being delivered by. And then lastly, here's another recommendation that was made was develop policy recommendations to better assist and prepare communities of color during the current COVID-19 pandemic, as well as future state emergencies. So glad to say that 2 of the 3 state legislative items the team were supported were passed, which were paid sick leave and workers' compensation for risk of exposure to COVID-19. Next slide. And so given the ERT's recommendations, I now invite you all to think about ways in which you can embed an equity, diversity, and inclusion lens into your work. So that not only can we improve our response and preparedness to a pandemic, but how we potentially move into recovery. And doing your work with an equity, diversity, and inclusion lens is not about changing your work, but more so how you do your work. And though we may operate under policies and systems that have been historically sanctioned and created, we can acknowledge that in both good and bad situations. Because if the bad news is the inequities and inequalities we face in today's society are created by policies, the good news is that policy is also the answer to undo all the harm that was created by those previously created policies. As we continue to live with COVID-19 and do our work, I leave you with these 5 questions that are intentionally very high level, but are applicable to any situation, as they are intended to be a starting point for incorporating EDI into decision-making processes. And so those questions are, what are the assumptions underlying this proposed goal, objective, and strategy? Can this proposal unintentionally burden traditionally underserved communities? Have you used a variety of data sources, so meaning including qualitative and quantitative, to identify the most effective communities? What communities should be prioritized in decision-making processes and why? So basically traditionally and historically underserved communities. And how will this proposed goal, objective, strategy benefit traditionally underserved communities? Will traditionally underserved communities have power in decision-making process? What type of decision-making power? Which, if we refer to the IAP2, which is the International Association for Public Participation spectrum. They share a nice visual of what that looks like and gives an explanation of community power in each step of engagement process, authentic community engagement process. And then have we clearly communicated these expectations with community partners and leaders? Again, it's critical for us to think about informing community in the way that information is received and reciprocated. And then how are communities that are traditionally left out of decision-making involved in defining success? Are these mechanisms in place for the communities to hold decision makers accountable? And then how are results evaluated and communicated? Oftentimes we think we can come to community and ask, and not give any feedback as to the progress or the process or the impact that they're having or the influence they're having on the decisions that are being made. And that's often very critical to keep the community members informed and a part of the process. Okay, next slide. And so the big takeaway here is for us to think about those partnerships with community, and not just communities, but also across multi-sectors. Equity should be considered to be embedded in all of our systems, as all of the systems impact us and our identities. And so I want to thank you all for having me today. I have a few shameless plugs on behalf of the Office of Health Equity. And so I encourage you all to check out our suite tools for advancing equity. We have one around authentic community engagement, framing data, and honoring all languages, and a few others. And then we have our monthly newsletter, which is Change the Story. This is a good way to get to know the office. We share many of our resources through this newsletter as well. And then we have our Equity Action Guide, which this was created by incorporating community voice from the beginning and asking community what's most important about their health. And so community voice was incorporated through the entire process, and then this data was disseminated in a form that community can use to advocate for change. And the nice thing about our Equity Action Guide is it's not just specific to any organization, agency, community member. It's everybody can use this. And with that, I leave us that equity is a responsibility of us all. We all need to be doing this together to dismantle historical injustice that are still showing up today. And then also just some other ways to connect with us are listed there, and then contact information. Thank you all.
Thank you, Christabel. That was wonderful. And I am excited to introduce you to our next panelist, who will definitely be taking it from theory into practice in the San Juan Basin region. So over to you, Lori Zazzaro.
Great, thanks so much, Marguerite. And I'm glad to be here today. As Marguerite said, my name is Lori Zazzaro. I am in Southwest Colorado. I represent La Plata and Archuleta counties and the entirety of the Southwest region with the emergency preparedness work I do. What I'm going to talk about today is our Equity and Emergency Preparedness program and how that is coinciding with what's going on with COVID-19. So next slide. So a little bit about who we are. San Juan Basin Public Health, we are a public health service jurisdiction. As I said, we are the local public health agency for the residents of La Plata and Archuleta counties. You know, we believe that we are leaders to achieve healthy communities and health equity, which is exactly what we're talking about today, that health equity component. Next slide. So I wanted to give you a little bit about our population demographics. I know each region is a little different, and when we're talking about health equity and we're talking about emergency preparedness, we really need to look into our population, our community, to see what are our needs. So when I'm putting together communications, what population do I have that might have a vision difficulty? So I might need to do the communications in a different manner. Or if we're doing a public event where we're inviting the community to come, how many of the folks there have a hearing difficulty where we might need someone who can communicate with them through other means. And then, so this just gives you a little bit of an overall what's going on in Southwest Colorado. We have a total of 100,000 residents in the entirety of Southwest Colorado. We are largely rural communities that are made up of our 2 Indian tribes, the Ute Mountain Ute and Southern Ute Indian tribes, and then the 5 counties. In my public health jurisdiction, of that 100,000 residents, we are providing services to 70,000 of them. Next slide. So let's get started on where we wanted to come up with, where did equity and emergency preparedness come from? And a lot of it stemmed from the 416 fire in 2018. So to give you a very quick and brief background on this, during that fire, I was representing as Emergency Support Function 8 lead, which represents the public health and medical services concerns during the fire. I did not have a playbook for what we need to do during a fire. I was pretty new in my role, but I realized that we really needed to engage some non-traditional partners to help get the word out as to what was going on and what people needed to do to help protect their health. So we started to engage with those partners where are the people in our community who have needs in an evacuation, in the pre-evacuation areas. In my region, I don't have a list of everyone who might have a need. As you saw on the previous slide, there's a lot of folks who might have a different type of need, and I don't have them all sign up for a registry. There's just too many people. So how do we get to those folks who need assistance in an emergency? So, and in a way that we can communicate with them that is relatable to them. So we reached out to our home health agencies, our cognitive and physical needs partners. We have an organization for that. Those who have medical equipment, those who don't have transportation. We really leaned on our partners, and through our healthcare coalition, I was very new to that too. So grabbed some email contacts from there and just started sending out situational awareness to all of those partners, so that we could really get the whole community to understand what was going on and get a grasp of what are some of the things that we need to be considering. Are there people who need help evacuating because they can't take their durable medical equipment with them? Maybe they can't carry it. So we had a couple of instances there. We also had folks who, a lot of people don't have air conditioning, and when you're told that when it's the height of summer, I mean, we were in the middle of June, and at night you open your window to let the cool air in, and during the day you shut it. Well, when you open your window and you're letting in smoke, and now you're having concerns in your home because you can't have the smoke in there. I mean, you can't breathe. So it's how do we capture all of these populations, and utilizing our healthcare coalition was great. What we did notice there, though, is we were missing contacts because not everyone was a part of our healthcare coalition. We don't have that buy-in yet at that point. The badging snafu was an interesting one. So a lot of us around the state are using the salamander system, and we were issuing badges to those who had evacuated, and we evacuated neighborhoods, but we also had evacuated our homeless camp. They were in the national forest. The forest has closed, and so they were also evacuated. So part of the badging miscommunication was there were bright green badges, and so people thought they were given green cards. And so that didn't bode well for certain populations. And then there were different badges given to those who were evacuated from the homeless camp versus those who were evacuated from a neighborhood, let's say. And so that also gave you access to certain resources, which we realized after everyone should have access to the same resources regardless of the badge and the badge color. So that was an interesting moment to a lesson learned to improve upon. And then, as I was mentioning with respiratory concerns, we had our largest skilled nursing facility who, in previous fires, we've had to evacuate individuals because of those pre-existing conditions during a fire. And then, so we were able to source some HEPA air filters. However, again, there were some folks in low-income housing who couldn't even afford to have a fan in their home. And so we were working with our Human Services, Emergency Support Function 6 partners to help provide for those who they just couldn't provide for themselves. I mean, as you saw in my demographics, we do have a percentage of folks who live well below the poverty line. So let's go to the next slide. Next slide. Thank you. So having those lessons learned, what can we do better? We kind of took the idea and made it into a reality. We started our Equity and Emergency Preparedness program. That was a grant we were able to do through the Office of Health Equity. Thank you very much, Office of Health Equity, for supporting us in this program. So how do we learn from that unexpected catalyst? How do we take those lessons learned and then make this part of our planning into something more sustainable? So we created this program to complement the work we were already doing in emergency preparedness and in partnership with our healthcare coalition, so we could focus a little bit more on that that equity component in how it relates to emergency preparedness. So we created a task force that included our partners from the Southwest Center for Independence. We have a local organization called Community Connections that works with folks with cognitive needs. Compañeros is our Four Corners Immigrant Resource Center. We were working with our local soup kitchen. And then we also started working with our school nurses to address the needs of our youngest population. So with those groups, I mean, we created that task force, and it started off with 3, then it grew to 5, and now we're kind of, COVID-19 has kind of hijacked a little bit of what we were going to do for the 3rd year with inviting more people to the group, but we still have a year to do that. So we started holding some specialized meetings to really look at our after action from the 416 fire, and then how do we move forward. So we started doing presentations to the community on how to build emergency kits, what to do for an evacuation, and then tying in that health equity into those presentations. We really want to prepare our community for emergencies, but we want to make sure we're preparing the whole community. Looking at getting buy-in on how we should communicate, and also getting buy-in on how we should communicate information with our community. I'm not an expert on how to communicate with every individual in my community, but my partners are. So how can we do better as public health in communicating with everyone? Because maybe it's not through social media and on our website. There might be other ways that we can communicate. Looking at training and exercise, we started introducing our partners who weren't traditionally invited to tabletop exercises and maybe weren't familiar with some of those FEMA incident command system terms. Starting to do those types of exercises with them so they understand, and then inviting those partners to community-wide tabletop exercises that maybe aren't sponsored by public health. Great example is yesterday, our airport was doing their tabletop exercise, and I invited my partner from Southwest Center for Independence so she could get an idea of what we're going to do if we have a mass casualty event at our airport, and how maybe she can provide some insight into maybe some people on the plane might have a need that others aren't considering. And then we started to educate our partners on health equity. So we held a workshop that had scenarios, and we had specialized equipment for them to use for maybe how someone might call 911 utilizing an iPad because they can't talk. We just really started having that open conversation with our partners, and I'm talking about partners from our local government, from law enforcement, from EMS, from the hospitals, public health, human services, just getting everyone together. One of the first questions in there was they don't know what the correct term they should even use when describing members of our community. Are they people with disabilities? Are they vulnerable populations? Do they have special needs? Is it access and functional needs? What is CMIST? So let's go to the next slide. So CMIST, this was a great talking point for us with that group to really drive home. There are many different needs that people might have, and they're not ones you might expect. Like, for example, right now with transportation and COVID-19, if you're someone who's told to isolate and quarantine at home, suddenly now you don't have access to go out and get what you need. And so you might need meal delivery, or you might need your prescriptions delivered to you because you're supposed to be isolating. You're not supposed to be at the local pharmacy getting the prescription that you probably desperately need for whatever that need might be. So really explaining that at different times in our lives, any one of us probably falls into a CMIST category. So when we're talking about COVID-19 and let's say communication, for our partners, it's really about sharing that situational awareness. And so during COVID-19, we've been hosting stakeholder calls. In the very beginning, this was 3 times a week, and it was extremely stressful because I'm calling all my friends. I'm like, yeah, we need you to get on this call with us so we can collaborate together on what we're going to do about COVID-19. It's new, it's scary, we don't know what's going on. We don't need to be spreading panic. But then also, how are we communicating to the public? We were using our social media, but then it turned into, you know what? I don't know how many on the call are familiar with trap lines, but in incident management speak and public information officer speak, that's having a location where you're either sending a person or you're posting information at specific points in your community. And in the beginning, you know, let's do this at the grocery stores, but then it turned into, you know what? How is this getting to our folks who are over at the soup kitchen? How is this getting to folks up at the homeless camps? So how do we expand our reach and utilize the tools at our disposal to, you know, make sure we're getting the communication out to all of our residents? When we're looking at medical, the medical component of CMIST and COVID-19, we started hosting weekly provider calls, and one of our big concerns was, how are we providing medical care after someone is diagnosed COVID positive if they don't have a medical home? So how can our providers, how can we get that word out so that if you are positive, now you're isolating at home, you're scared, you might be having further issues, you don't know who to talk to or follow up with. How do we connect those dots? And then with our residents who might have medical needs, how do we connect them to the resources they need? Because now we're at a stay-at-home order, and again, you might need to go and get your prescriptions or whatever it is you might need. So we really partnered with our human services group, and how do we, because they were working with like food insecurity and with that kind of, how do you get what you need when you're used to going to get it yourself? So partnerships to help the residents, then how do we get that information to the residents? When we're looking at the independence component for residents, before this, we were trying to empower all of our residents to understand what to do in an emergency, which is why we were doing the workshops with the emergency kits and what do you do when you evacuate and how do you communicate with your family? How do they know where you are? Developing those lists. I know I've polled many people before in the past on, do you have an emergency kit at your home? And then it's usually not it's not like a 50-50 or 100% of people raise their hand that they have an emergency kit ready to go. I'm sure everyone now has plenty of toilet paper ready to go, but that's not all you need in an emergency. Looking at supervision, we had an incident within an incident, I would say, during COVID-19. We have fires in Southwest Colorado quite frequently, as many others of you might. And we had a fire, the East Canyon fire in Montezuma County. Well, we had just had a tabletop exercise with our partners at Community Connections, and I knew there was a host home in the path of the smoke and the fire. And so we did outreach to them to see, is everyone okay? So, I mean, there's just so many different aspects of how CMIST and COVID-19 really intersect right now. How about we go to the next slide? I'm trying to hurry up because I know we're gonna run out of time, sorry. Talking about our partners, I think I'll just highlight working with the Southern Ute Indian Tribe and the Ute Mountain Ute Indian Tribe, and then in New Mexico, the Jicarilla Indian Tribe. It brings a whole new perspective on how we're doing our planning. And so right now, I mean, what's going on in the Navajo Nation in New Mexico is a strong concern for us in Southwest Colorado and for our tribes. Our Southern Ute Indian Tribe is still at a stay-at-home order. They haven't moved to safer at home because they're watching out for their tribe, and this is what they think is best for the tribal members and their staff. So how we've been helping them during COVID-19 is partnership on community testing, providing subject matter expertise, and then supporting them with contact tracing, with support, like doing some of the contact tracing for them and training their staff so that they can also do the contact tracing that they need. I also would like to talk about what we've been doing with our homeless population. As I mentioned before, putting up trap lines, so those specific locations where we're providing information that's accessible to those who are homeless. and working with our partners who support that population so that we're doing targeted testing and outreach. So we have been going to the camps, we're going to our soup kitchen to provide community testing, specimen collection to see what's going on in our homeless population, because they might not be going down to our drive-through testing. I mean, drive-through kind of, to me, it sounds like you need to have a car for that, right? So how can we bring the testing to them versus that they have to go to the testing, making it as easy as possible. We've provided hand washing stations as well, because we want to make sure, I mean, hygiene is a strong component. And then we actually work with the camp hosts to see, hey, here are the recommendations for how far tents should be set up so that you're properly socially distancing, and providing that guidance and information. So having that partnership with our camp host has been really strong. And let's go on to my last slide so we can wrap this up. So my actionable advice for this group is knowing your local resources. In the very beginning, our public health, which is separate from our human services, we started a local resources call and then transitioned that over to our human services group, who then put together this website of resources, which I've listed here. And then we have to remember to be equitable in those resources, because there are people right now who are now experiencing CMS needs that weren't before. So whereas someone might be on isolation and quarantine and they might need meals delivered to them, someone else might just need someone to do their grocery shopping, like go pick it up from the store and the easy pickup or whatever it's called, and then just drive it to them. So making sure our resources are equitable for all types of people who might need help right now in isolation and quarantine. Building those stakeholder relationships in advance is key. When we had our first stakeholder call, we had 120 people show up. And as I said, we're not a large community, but you've got to have that buy-in so that they all want to hear your message and being part of it. The second part of that is meeting etiquette. So being able to keep order. After one of my first couple meetings, some of my new partners to the group were taking notes and posting them on Facebook. And so I had to kind of explain that this is a stakeholder call. This is not a general public forum. So let's keep the conversations between all the partners here. And then in the beginning, when everyone was confused, it was chaos. It was kind of like no one knew what was going on. No one knew what to believe. You had to rein in that meeting and I had a script that I would read at the beginning of the meeting to keep it on track, and then knowing how to facilitate a meeting so that your partners don't derail what's going on. When you have 120 people, you really need to make sure that you're staying on point. And then knowing your technology. We've been using Zoom, and I don't know what the technology for GoToWebinar is for closed captioning, but I know that if we needed to, we could use that through Zoom. So I wanted to make sure that was an option in however we were communicating with our partners and with the community at large. And then really knowing the ins and outs of Microsoft Outlook. You can't send a calendar invite to 250 to 300 people. It's just a mess. So that's all I have for the group today. Thank you so much for your time.
Thank you, Laurie. And I'm just going to move things right along. We're going to move into the county perspective. We have both Tom Gonzalez and Kelsey Lyon here. Tom, I think you might be muted.
Yes, thanks for having us. This is Tom Gonzalez, Public Health Director for Larimer County Department of Health and Environment. We're going to share some of our ethnicity data around COVID-19, our cases, as well as what are our plans moving forward to get good outreach within some targeted communities. So I'm going to turn it over to Kelsey Lyon, and she's going to go over the data, and then I'll wrap it up with the last slide on our strategies.
Hi everyone, I'm Kelsey Lyon. I am the Public Health Planning Supervisor for Larimer County Department of Health and Environment. We really started diving into our race and ethnicity data pretty recently. Just to have some high-level demographics is that Larimer County has about 360,000 individuals living there. We have two kind of urban hubs of Fort Collins and Loveland, and then we have rural communities surrounding those areas. Overall, our county race and ethnicity breakdown is that we're about 83% white, 11% Hispanic, all races, and then we have smaller percentages of Black, Asian, American Indian, Alaska Native, Hawaiian, Pacific Islander. So really in terms of populations, a lot of our focus is focusing on the Latinx population. When we started looking through some of our numbers, we saw that although 82 or 83% of our population is white, we only had about 44% of our cases, of our COVID cases associated with the white population. And in the inverse, while we have about 11% of our population being from the Latinx community, about 22% of our COVID cases were associated there. We do have right now a lot of unknowns. About 30% of our cases are unknown in terms of race and ethnicity, and we're diving into that a little bit more to see if we can get more precise data at this time. If you go on to the next slide. This is just another way to look at the same data. Over the course of the pandemic, we can see the disparity in the burden of disease among our racial and ethnic communities in Larimer County. Among white non-Hispanic residents, we had about 162 cases per 100,000 residents, while in the Latinx community of all races, we had about 600 cases per 100,000 residents. Other racial groups in the community have very few cases, specifically just because that's our demographics. So that's 6 or fewer, and we'll continue to monitor these groups just to make sure that we are outreaching and monitoring appropriately. But because of the small numbers, it's not really cause for immediate concern. Additionally, we know from research across communities in the US that certain populations are more vulnerable to COVID-19 infections, including essential workers, such as healthcare providers, agriculture and meat processing workers, and retail employees. These employees are going to work every day to provide for us. They're not able to work from home and socially distance as much as some of us are. And we suspect that some of the racial disparity might be in part driven by this greater percentage of essential workers among the Latinx population. And that is what we're diving into this week and early next week, is really evaluating the data to look for opportunities to protect these vulnerable communities, reduce our disparities, and decrease infections overall. And Tom can talk a little bit about some of our initial strategies and what we're looking at moving forward on the next slide.
Thank you, Kelsey. Yeah, next slide. Yeah, Larimer County Public Health, we dove in last year with a 5-year strategic plan, and one of our focus areas is becoming health strategists, being conveners within our community to tackle difficult health issues. And one of those that surfaced through the discovery phase was equity and health equity. And right here, COVID-19 is shining a bright light on the inequities within our community. So our mission here is working to provide everyone in Larimer County the opportunity for a healthy life. And that key word, everyone. So we are working together with our community to hire bilingual and bicultural staff on our case contact and monitoring outbreak teams. We are working with our library districts, or our school districts are their language, culture, and equity coordinators with an objective to really gain trust within the Latinx community. We are going to be following up with mobile home parks, apartment complex property managers to ensure properties are safe. And also, as you heard on the previous presentation, more access to testing. We do have our community-wide drive-through testing, but we want to bring the testing to the community. So we're working on potential ways of providing that. Also developing our case contact and monitoring video in English and Spanish. And we're working with our partners who work with the Latinx community, develop messaging and outreach. Again, our library districts and our school districts have been fantastic partners in this regard. I'm really excited. We are going to be hiring a Latinx outreach specialist for individuals who are familiar with the Latinx community, the values and the impacts of COVID-19. One of the challenges has been when we're doing our contact tracing is answering the phone and answering the questions by many of our Latinx community because of the lack of trust with the government. So we're working closely with our community members to build that trust, and that doesn't happen overnight. So we're working diligently to be able to get folks to understand when we're contact tracing, that information is private It is not to be judgmental. It's information to be used to suppress the virus spread in COVID-19 and learn how the virus is spreading within our community. So that's going to be a big target with our outreach specialists. And then in recovery, we'll be utilizing our strong partnerships through our Community Health Improvement Plan and all our over 40 partners to reassess needs and strategies to meet those needs in our community. That's our presentation. Thank you for the opportunity to give Larimer County's perspective.
Thank you both so much. And I want to move things along because we do want to save time for Q&A. If you do have a question, please leave it in the chat. But over to you, Luis Murillo.
So a little bit about the town of Center. We're a very small town located in Southwest Colorado with a population of 2,400. The average income household, or the household income, is about $36,000. That puts us at a poverty rate of 25%. Highly Latinx, that is our main demographic. So a lot of our folks in town will speak Spanish as their main and sometimes their only language. So the reason, next slide, please. The reason why I got involved is because late April, early May, we were seeing a rise in numbers in regards to people infected with COVID. And it was quickly identified that the folks that were getting infected were the Spanish-speaking population, as well as some of the Guatemalan community members. Am I still on? Can you guys still hear me?
Yes, we can hear you. Continue, please.
All right, awesome. So what we decided to do, I got involved because I'm a phase that the community recognizes late in the fourth quarter of the school year. When we decided to go to remote learning, I started putting out videos so people knew me. I was a person of trust. What we decided to do when I got involved is we put together a grassroots effort that was composed of community members. So it was really community members helping community members, or neighbors helping neighbors. This whole plan came from an equity and access lens because we felt the information that our community members needed to receive needed to be presented in their home language, as well as it needed to be culturally sensitive. So we gather and we went about disseminating information with the 3 pillars of community service and leadership. So we created a 3-phase plan, which phase 1 was a social media campaign in which I and other folks created videos with the latest facts and information regarding COVID. These videos were disseminated via WhatsApp, which is an app that is commonly used amongst our community members, as well as Facebook. And we found that a lot of our community members were getting that information that way. Then we decided to go with the phase 2. Actually, let me backtrack. We found that pretty quickly those videos were getting lots and lots of views. They were surpassing, I guess, the population of Center. The population is 2,400, and a lot of our videos got to 3,000 and above. Phase 2 of our plan was personal contacts. Earlier on, I heard a lot about relationships. So our teams, our neighbors, reaching out to neighbors, these folks have personal relationships with our community members. So we decided to reach out that way and say, hey, are you doing okay? Did you see that information? What do you need? We started taking note of what people needed so that we can follow up with whatever they needed. So that was phase 2. During phase 2, we reached 400 people via phone, which then led us to phase 3. During phase 3, we decided to actually get out to the community. So my team was composed of 14 individuals, and we divided the town of Center into 7 different areas, which then, as pairs, we went out and actually knocked on doors of the folks that we felt that we did not reach via social media or phone calls. When we knocked on doors, our purpose was, again, to pass out information as well as check in. But more importantly, we wanted to give them a sense of hope. We felt that a lot of people were kind of running away. We were getting the stigma of, don't come to Center. And we wanted to say, hey, we are here. We are coming to you. So that was our phase 3. And then at the end, what we accomplished, we estimated that we got about 5,000 views on our videos, over 3 personal contacts, about 6 visits, and we passed out 100 masks, cloth masks, as well as about 1,000 disposable masks. We passed out some gloves, and we just felt that our efforts were very welcome because they were, one, in their language, and 2, from people that they knew. And again, I want to really emphasize the neighbors, helping neighbors. And that is all I have.
Wonderful. Thank you, Luis. We're just going to advance ahead. We do have that video that you mentioned, Luis, we'll be posting online. And I would like to open it up now to Q&A. Please leave them in the chat. And thank you to everyone who's still on. I know we're going a bit over time. We are recording this again, so you will be able to access this presentation in full on our website if you do have to jump off. So I will pass it over to Christy Dune, who is the regional manager for Luis's region, and that's really how we found Luis as a contact doing this work. So I encourage all of the local governments on the call to really build the relationship with their regional manager within DOLA. So Christy, over to you.
Thank you. So still have the question panel open. So if you have something you want to ask one of our panelists, please do. But to get things started, for any of the panelists who are interested in answering this, have any of you developed strong partnerships with foundations or the philanthropic community that are doing equity work within your region? And if so, do you have any advice about how to efficiently coordinate efforts in yourselves and other nonprofits? Tom or Kelsey, do you have any comments about the work you guys are doing in Larimer County in this area?
Yeah, so I'm trying to think of how to succinctly wrap this up because that was a big question. So our community health improvement plan has really diverse partners that come together to try to work collaboratively towards, in our priority areas, it's promote mental and emotional well-being and then access to quality childcare. And really both of those have a huge impact based off of COVID. And so really we did a lot of outreach trying to figure out common ground where, you know, some of the service providers, some of the foundations, some of the healthcare facilities all could come together to kind of coordinate around one large effort. So I think, you know, this is a super vague answer, but for all of our partners that we reach out to, it's really figuring out what role they play in this bigger collaborative effort and then utilizing that specific expertise, not necessarily asking them to go outside of their lane, but valuing what expertise they bring within their lane and how that complements other people's expertise. We're really lucky in Larimer County that we have a really, really collaborative group. And, you know, far before COVID and far before my time and Tom's time in Larimer County, we've had really strong partnerships with a lot of the foundations and various organizations in Larimer County. And public health has continued and is growing to be an essential player in conversations around social determinants of health, around access to education, and really building those relationships. But it's intentional relationship building and honoring where people are coming from, as well as honoring their expertise. I know that's super vague and not tangible strategies, but I can also think on that as well.
Sure. Thanks, Kelsey. I think that intentionally reaching out, intentionally identifying people within your communities that need to be engaged is a really important part of finding ways to be more equitable in situations like we're in now, as well as in our everyday work within our communities. I think that's great. Luis, a question for you has come in. Who did you find were the most powerful connectors for your community outreach teams?
What I found the most powerful connectors were folks that our community already knew. In this case, the team that I put together has a base of a team that I already have through school, which is a parent involvement group whose mission is on equity. So these are, again, faces that were familiar to our community members.
Great, thanks. Any other questions from the audience?
I might jump in here. Thank you, Christy. And thank you to our audience for the thoughtful questions and your participation and listening in. I'd like to also respect our panelists' time, and I know that we have gone over. So thank you to all of our panelists for their not only really thoughtful work within their communities, but for sharing their experiences here on the webinar series. And we will be announcing our future webinars in the coming weeks. So please feel free to check back on our website. And with that, I will end the webinar. Thank you all again.